Now we will start part 2 of heart failure pharmacotherapy. Our last slide was about heart failure treatment guideline. As illustrated here, patient with HFrEF stage C, NIHA class 1 to 4, so they are eligible to start ACE or ARB and beta blocker as a first line, and beta blocker can be added when the patient is stable. Second step is to add diuretic or loop diuretic in case the patient is volume overloaded or have edema. If the patient is African American and he is persistently symptomatic despite optimal doses of ACE or ARB plus beta blocker, so he is eligible to start hydralazine dinitrate. If patient in class 2 to 4, provided that his eGFR more than 30 ml per minute and potassium less than 5 milliequivalent per deciliter, so this patient are eligible to start aldosterone antagonist like eplerenone and spironolactone. What about digoxin? Currently, digoxin is not a preferred medication for heart failure patient. It has a lot of toxicities and side effects with its use, so it is limited to be used to decrease hospitalization, meaning it decreases the hospital admissions of patients, and also have beneficial effect if patient is having heart failure and atrial fibrillation because it decreases the cardiac conduction. So it's considered if the patient still having symptoms despite GDMT guideline directed medical therapy, and common dosage are 0.125 to 0.25 milligram daily. Patient need not to be loaded in heart failure, and the target plasma concentration is 0.5 to 0.9 nanogram per ml because it is a narrow therapeutic index drug. In elderly, the preferred dose is 0.125 because of impaired renal function. What are the complications of digoxin? As we mentioned, toxicity. Digoxin is having a high chance of toxicity, especially cardiac arrhythmia, because it affects the cardiac conduction. GI complaint, and this is the first symptom that patient can experience as nausea and vomiting. And so if a patient is coming to the emergency with nausea and vomiting and this patient is on digoxin, so you need to suspect digoxin toxicity. CNS manifestation like drowsiness and seizures may happen also. Also be aware that digoxin toxicity can occur even at lower or normal blood levels due to some drug interactions with low potassium or magnesium because they compete with the same receptors on sodium potassium ATPase pump. So when there is less potassium to compete with digoxin, more digoxin will bind to the receptor, causing a toxic effect. Also, hypothyroidism can increase the toxicity. Some drugs that interact and increase digoxin level like amiodarone, dronedarone, verapamil, clarithromycin, and erythromycin. Also, poor renal function can elevate digoxin level, and this is evident in elderly who are usually having poor renal function, so it's preferable to start low dose and keep them on low dose of 0.125 milligram. A new drug introduced recently, which is ivabradine, is available in two strengths, 5 milligram and 7.5 milligram. The brand is Brucoralan. So this medication is having a recommendation in patients who are stable chronic heart failure, reduced ejection fraction, who are receiving guideline directed medical therapy including beta blocker at a maximum tolerated dose, who are in sinus rhythm with a heart rate above 75 ppm or greater. So how does it work? So it inhibits the funny channel in the pacemaker in the SA node, so it will reduce the heart rate and more blood flow to the myocardium will occur. What is the place in therapy? As we mentioned before, patient need to be having heart failure, reduced ejection fraction, and resting heart rate of 70 ppm or greater despite maximum tolerated beta blocker dose. Also, if patient is contraindicated to use beta blocker, so it is optional to change to ivabradine. What are the dosage? The normal dosage for all patients is 5 mg twice daily, can be increased to 7.5 twice or reduced to 2.5 mg twice according to the symptoms and heart rate of the patient. In elderly above 75, the starting dose should be low, up to 2.5 twice daily. Treatment must be stopped if heart rate is persistently below 50 beats per minute or bradycardia despite dose reduction. It has another indication for angina, and the treatment of ivabradine need to be stopped if no improvement after 3 months of medication trial. Another new drug class which is ARNI, angiotensin receptor neprilysin inhibitor, which is sacubitril valsartan. You may came across to this medication, which is Entresto. Is available as 50, 100 and 200 milligram doses. So it's recommended in patients with chronic symptomatic heart failure, reduced ejection fraction, New York Heart Association class 2 or 3 who tolerate ACE or ARB. So the patient need to tolerate ACE or ARB, but replacement of ACE or ARB with ARNI will further reduce morbidity and mortality. So it has a morbidity and mortality benefit. How does it work? It's neprilysin and angiotensin receptor blocker. So neprilysin blocks the breakdown of vasoactive peptides, which are here like PMB, AMB, CMB, bradykinin, adrenomodulins. All these are vasoactive peptides. They produce a favorable effect in the heart that cause vasodilation, decrease sympathetic nervous system activity, and causing diuresis. All these are benefits for patients of heart failure. So this effect is broken by neprilysin, which degrades these vasoactive peptides. Neprilysin inhibitor, which is sacubitril, will block the breakdown of neprilysin, so it will increase the activity of vasoactive peptides. But in the same time, neprilysin increase angiotensin too, so we need to add valsartan, which is ARB, to block the effect of angiotensin. So we have sacubitril, which is neprilysin inhibitor, which boasts the positive effect of natriuretic peptides and vasoactive peptides by blocking the breakdown by neprilysin, and valsartan, which is ARB, which attenuates the negative effect of angiotensin 2 by blocking the RAS system. So what is the contraindication? It's similar to ACE or ARB. So patient who's having history of angioedema to ACE or ARB, patients who are already on ACE, they should stop ACE first and start ARNI. And there is a time span. The patient must wait 36 hours before stopping ACE or ARB to start the ARNI. The side effects are similar to ACE or ARB, which is angioedema, hypotension, impaired renal function, and hyperkalemia. So what is the criteria for initiation? So patient need to having a systolic blood pressure of more than 100 millimercury, because it usually causes hypotension, and also eGFR should be more than 30 ml per minute due to kidney injury by the valsartan. Starting dose of 49 by 51 mg twice daily, which is the Entresto. 100 is recommended for all patients. Then the dose can be doubled after 2 to 4 weeks to the target dose, which is 97 by 100, which is the Entresto 200 twice daily if the patient tolerates this dose. The starting dose can be reduced to 24.26 twice daily, which is Entresto 50 in patients who never taking any ACE or ARB, or are taking low dose of ACE or ARB, or they have a low GFR less than 30, or moderate hepatic impairment of child PO classification of class B. So the product available in these three strengths: 50 mg, 100 and 200 mg. What about the dosing and shifting between ACE and ARB to ARNI? So if a patient on moderate or high dose of ACE inhibitor, which is more than 10 mg of enalapril or equivalent, or more than 160 mg of valsartan or equivalent, so this patient are shifted to Interest 200 twice daily, and the dose doubled after 2 to 4 weeks with target maintenance dose of Interest 200 twice daily. If patient is on low dose of ACE inhibitor, like less than 10 mg per day in enalapril or equivalent, or less than 160 mg per day of valsartan or equivalent, so this patient will be shifted to Interest 50 mg twice daily and the doubling of the dose every 2 to 4 weeks, and with target up to Interest 200 mg twice daily. So this is why we see a lot of patients on different strengths of Interest based on prior use of ACE or ARB, their renal function, or the shift between medications. So to conclude all what we discussed, when to initiate, add or switch according to the evidence-based guideline for heart failure. So patient with heart failure, reduced ejection fraction stage C, who have structural heart disease or having symptoms of heart failure, so we need to start treatment with ACE or ARB. When the patient is stable, we add beta blocker. Diuretic is added if needed when patient having fluid overload. So for persistent fluid overload, so we need to titrate diuretic, so increase the dose of diuretic to produce like 0.5 to 1 kilogram per day loss of fluids. So if the patient is African American and persistently symptomatic, so we need to add hydralazine isosorbate dinitrate. So for patients who are unstable on ACE or ARB, who are NIHA class 2 to 3, we can switch them to ARNI to better reduce morbidity and mortality. For patients with eGFR more than 30 and potassium less than 5, who are NIHA class 2 to 4, so these patients are eligible to add aldosterone antagonist to reduce morbidity and mortality. Patient having heart rate above 70 with maximum tolerated beta blocker dose and in sinus rhythm, so this patient can use ivabradine. So what is the pharmacist intervention for treatment of heart failure? We can do a lot of work here. We can focus on non-adherence, so we can capture the non-adherence of patient to lifestyle or medication. Unnecessary medication or duplicate therapy can be identified. We can see a patient on ACE inhibitor or ARB or ACE inhibitor and ARNI, so we need to do our intervention to contact the prescriber to stop one of these medications. Dose may be too high, like in case of spironolactone in CKD, and the dose is not reduced to half. Dose prescribed may be too low, like patient having ascites or fluid overload and still on low dose of furosemide 40 mg BID, and we have an option to increase the dose up to 600 mg, so this is our intervention. Ineffective medication, like using metoprolol tartrate, not succinate, because the clinical trial proves the mortality benefit from tartrate salt more than succinate. And adverse drug event, we can see patients having orthostatic hypertension who are on carvedilol, so we can identify this one as a side effect from carvedilol, and we can report it in the adverse drug event reporting system in the hospital. Let's apply our knowledge in a patient case. So the presenting complaint, patient MK 68 28-year-old African American who is admitting to ED with progressive worsening shortness of breath, and the present complaint is that I cannot seem to catch my breath. So the patient have difficult breathing or dyspnea, which is the main symptom of heart failure. What is the HPI? History of presenting complaint. He is unable to climb flight of stairs or walk more than a block before developing shortness of breath. He is unable to sleep in bed due to shortness of breath. These are new symptoms that have not become progressively more, and he report to compliance to his medication. So what is his past medical history? He have heart failure, reduced ejection fraction in August 2014, MI with drug-eluting stent, hypertension, dyslipidemia, and type 2 diabetes. Her medication list includes aspirin, atorvastatin 40, metoprolol tartrate 25 mg twice, lisinopril 10 mg, metformin 1000 mg twice, furosemide 40 mg daily, digoxin 250 mg. His lab results include sodium potassium chloride, which are within normal range. His NT-proBNP is very high, above 2000, and this is normal for patients with heart failure to having elevated NT-proBNP as a biomarker. Most of the blood results are within normal. His digoxin level is 0.8 nanogram and the maximum level should be 0.9, so he is in a borderline. His vital sign including blood pressure of 95/68, heart rate 103, temperature 37, respiratory rate 22, and weight 87, and his weight was 79 kg 2 weeks ago, so he gained some weight. The first question on discharge: which of the following would be appropriate intervention to optimize Mr. MK pharmacotherapy? It's discontinue digoxin, change metoprolol tartrate to metoprolol succinate 50 mg daily, change metoprolol tartrate to atenolol 50 mg daily, or to initiate ivabradine. So in this case, as we mentioned, the evident beta blocker with mortality benefit are metoprolol tartrate, succinate, not tartrate, so better to shift patient to the metoprolol succinate. Next question: which of the following medication would be added to his medication at this time to reduce the risk of death? Is it valsartan, aliskiren, eplerenone, metolazone? So this patient renal function is normal, potassium is normal, he is ACE and beta blocker, and he is having heart failure, reduced ejection fraction. So what is missing now and will be helping to reduce his mortality? Of course, it will be eplerenone, which is the aldosterone antagonist. Last question: which of the following pharmacotherapy changes appropriate to make further improve his survival? Is it change lisinopril to valsartan 160 twice, or add ivabradine 5 mg twice, or change lisinopril to sacubitril valsartan 49/51 twice, or change to sacubitril valsartan 97/13 twice? So we are looking for further improving survival. So this patient is stabilized on ACE. So the good option is to change lisinopril to sacubitril valsartan. We will start with the 100 mg twice daily because this is the starting dose for shifting. And thank you, and I hope you learned something new, and this is some of the reference for your information, and see you in next episode.